University. His research, which focuses on machine learning and decision-making under uncertainty, has been recognized with 3 Best Paper Awards and 3 Influential Paper Awards. He received an Outstanding Educator Award for his contribution to AI teaching and research and outreach. Mr. Littman is a fellow of the Association Advancement of Artificial Intelligence and the Association for Computing Machinery, and recently served as Division Director for Information and Intelligence Systems at the National Science Foundation. His book, Code to Joy, Why Everyone Should Learn a Little Programming, was published in October 2023 by MIT Press. He chaired the panel that wrote the 2021 report for the 100-year study on artificial intelligence, and will be chairing the standing committee overseeing the work on the 2026 report. He also co-chaired and co-authored the National AI R&D Strategic Plan. So I'm pleased to welcome him to tell us a bit about AI here at Brown and the directions that we're going. Please come up.
Thanks very much. Hi, everybody. It's great to be here. So I'm Michael Littman. I am the Associate Provost for Artificial Intelligence. If you know what that means, please let me know, because this is it's a new job. It's new to me and it's new to the university. And it uses a bunch of words that nobody's really sure the definition of. So if you have any thoughts, it would be great to just let me know what's going on. I'm actually married to a doctor who did her residency at Women and Infants, and she would always tell me about grand rounds. And I never thought that I'd actually get to speak at all at a grand round. So this is very exciting for me personally. So thanks for all you do. Thanks for having me. I wanted to say, okay, so I'm being a little cheeky about whether I know what an associate provost for AI does. So let me tell you a little bit about what I think my job is and why it might be relevant to you guys. So as was mentioned, before coming here immediately, well, I was at Brown for many years, but I did a rotation out to the federal government, and I worked at the National Science Foundation for the last 3 years. And I had, I was there during the transition between sort of pre-GPT to post-GPT. And like everywhere else, it had a really big impact on the agency and the federal government broadly. What I went to the National Science Foundation to do was to coordinate AI research for academics across the country, which is, niche, right? It's just one topic. It's one little sub area. But all of a sudden, it was like everybody's business. And so what we realized at the NSF is that the biology directorate, the engineering directorate, the geosciences directorate, the math and physical sciences directorate, the social behavioral economics directorate, like everybody was doing AI or needed to be doing AI. And so I had this wonderful opportunity to help coordinate efforts across the agency about what everybody was doing. I was trying to support the kind of work that was happening in those directorates. Wasn't taking it over in any way, but it was it's exciting. I've been thinking about these topics for a really long time, and I got to share my thoughts with people in all these other fields. So when Brown decided, hey, yeah, I think we kind of need somebody to help coordinate efforts here at the campus as well, I was very excited to apply for that position. And now I've started. It's about 3 months now that I've been doing this job. It's nice to be out of the federal government. It got really bumpy there at the end for me. I had, in part of my coordination with other federal agencies on AI, I worked with my good friends at USAID, who are no longer at USAID. So, and they're not doing AI anymore, and they're not doing anything anymore. And so I learned a bit about sort of global health equity ideas and the ways that AI might contribute to them, but then was very sad to see this organization really kind of disassembled before our eyes. So that was a huge bummer. The pieces of my job that I think are potentially relevant, the things that were in the job ad and that I thought that I'd be doing, a little broader than this, but it's plenty broad already, which include how Brown is responding with respect to AI in research, in teaching, in university operations, in policy across the university, and communication about AI to other people, because, I don't know, I had to throw that in too. And that's turned out to be the bulk of what I've been engaged with so far. And but I guess today is sort of communicating about AI and communicating about the role. But Brown as a university really is taking this very, very seriously and trying to take it to do it in the most responsible way possible, right? So there's so much hype, there's so much craziness around the stories that we're hearing about AI, but there's also some real opportunities, right? And I think that that in global health equity in particular, one of the things that modern AI chatbots can bring to bear is carrying sort of knowledge and inference and expertise to far-flung corners of the world, right? So there's lots of places where it's just hard to get all the data and all the knowledge to where it needs to be, and these tools can be really helpful. That said, they're also quite new. So, and we already know that there's plenty of holes in them. There's things that they do that are weird. And so it really is incumbent on all of us to try to figure out, okay, if this is helpful, how do we make sure that we deploy it in a way that really brings out that helpfulness and doesn't exacerbate other issues? So, so I think it's really great that people are engaged with this topic. I look forward to hearing what the panel has to say in particular. But I think that's mostly what I can tell you about. I'm happy to answer questions. I never know what people need to know, but I'm happy to share things with you. If not now, please feel free to reach out. My official office is my regular computer science office up the hill, but I've been traveling around a lot. I got to speak in this very room. I think it was this room. Was it this room? I think so. Just a couple days ago on the topic of AI for RNA, for trying to analyze RNA systems. So, which is, again, also a really exciting topic. So, okay. So with that, I will turn things over to the panel, and thanks everybody for being here.
All right, thank you all so much. So this is a little different than the format we've usually had for our Global Health Grand Rounds. Typically, we focus on one faculty member and their international counterpart and the very specific research that they are doing somewhere in the world related to global health equity. But for today, we wanted to bring together a panel of faculty here at Brown who are looking at this issue, a specific topic, in this case, artificial intelligence and technology, and looking at it from some slightly different directions and thinking about how it can be used as a tool to really reduce inequities around the world, including here in the US and in countries everywhere across the planet. And we're going to hopefully learn quite a bit from them. So I'm very pleased to introduce our panelists, starting to my right, Dr. Hamish Fraser, trained in general medicine, cardiology, and knowledge-based systems at Edinburgh University in Scotland, and in clinical decision-making at MIT and the New England Medical Center. His work has led to the migration of medical informatics tools and expertise from high-income countries to some of the most challenging environments in low-income countries. Dr. Fraser has previously held grants as PI from the CDC, the Rockefeller Foundation, and IRDC Canada for e-health work in Rwanda. From 2015 to 2017, he held a Marie Curie Fellowship from the European Union Horizon 2020 program, and he is currently co-editing and co-authoring a new textbook on global health informatics and digital health. In 2021, he received an NIH R01 grant with Professor Hogan here at the School of Public Health and Anne Mwangi at Moi University in Kenya, entitled Data Science for Decision Support in the HIV Care Cascade. This project has built prediction models using machine learning techniques and deployed them using the Open MRS electronic health record with the goal to improve HIV care at the AMPATH clinical sites in Western Kenya. To his right is my colleague, Dr. Stephanie Garbern, an associate professor of emergency medicine and director of medical student research here at the Warren Alpert Medical School at Brown University. She completed her residency training in emergency medicine at Beth Israel Deaconess Medical Center, a fellowship in global emergency medicine here at Brown, at a time when I happened to be the fellowship director for the Global EM Fellowship, so we go way back. And she obtained a Master's of Public Health degree from Harvard School of Public Health and a diploma in tropical medicine and hygiene from the London School of Hygiene and Tropical Medicine. Dr. Garbern's research focuses on leveraging technology, including mobile health, wearable devices, and prediction models to improve emergency and critical care for patients with sepsis and infectious diseases, including COVID and Ebola. She has worked clinically or on research projects in Bangladesh, Liberia, Lebanon, China, Rwanda, Guatemala, Honduras, Peru, Ghana, and Tanzania. And she also has served as a volunteer emergency response physician and consultant for International Medical Corps. And finally, to her right, Dr. Rochelle Rosen is a medical anthropologist and a research scientist at the Centers for Behavioral and Preventative Medicine at the Miriam Hospital, an associate professor in the Department of Behavioral and Social Sciences in the School of Public Health and the Department of Psychiatry and Human Behavior at the Alpert Medical School. Her primary research interest is in using qualitative data to effectively design culturally relevant behavioral health interventions. Her grant-funded research experience includes preventative healthcare issues in the South Pacific Islands of American Samoa, mobile health-delivered health promotion, and the acceptability of HIV prevention research. She has a particular specialty in using qualitative research model methods for translational health research in behavioral and preventative medicine. So please join me in thanking all of our panelists for being here today. So I'm going to start with the opening question specific to each of our panelists, and then after that, ask them some more general questions about their work. And then we're going to open it to questions from the audience, both our in-person audience here in this room and the many people joining us online via our Zoom webinar. So we'll get lots of chances to ask them detailed questions. So first question to Stephanie. Tell us about your work in Africa and South Asia developing clinical decision support tools and the impact they can have on patients, providers, and health systems globally.
Yeah, thanks. And it's great to be here. And thank you so much for having me on this panel. I am an emergency medicine physician, so I think in some ways it's weird to kind of be on like a digital health panel because I don't think I would have thought this was where my career was going to go like 10 years ago. But I kind of got really interested in the power and the potential of digital tools from my work doing global health research and clinical work in global settings, especially in low resource settings. And being a clinician anywhere is extremely challenging. And it's even more challenging when you have an idea of what you want to do for a patient, but you don't have the resources to do it. And I've really seen over the course of, the past decade, the real potential of digital technology to overcome some of these barriers. It's also not the solution to every health problem or public health problem, but there's a lot of exciting potential. So my current research is focused on creating digital-based interventions to hopefully help improve mainly sepsis care in Ghana, Rwanda, Uganda, and Bangladesh are where my projects have been. Currently mainly focused in looking at a wearable-enabled decision support tool for pediatric sepsis care in Bangladesh. And I really see these tools as just being one of many tools available to clinicians and researchers that can help overcome some obstacles where other tools have not been a great solution so far.
Okay, thank you. Next for Hamish. As physicians, many of us tend to think of the topic of electronic health records as boring at best, annoying at worst. Tell us why they are so important for healthcare delivery, especially to marginalized populations, and the work you have been doing to improve access to them for everyone.
Thank you. First of all, for inviting me here, and looking forward to a really good discussion. So it's a pretty fair question. It's a little crazy to start developing medical record systems like that to work in very low-income settings. But when I started to work with Partners in Health about 25 years ago, and they had just developed a very, very pioneering project to treat drug-resistant TB in Peru at low cost. But it's a long, complex chronic disease management issue. And so having got a huge Gates grant, they need to scale up from about 70 patients to about 20,000. And you can't do that unless you have very good records. And you have to be able to track what's happening over time in very detailed ways. And you have to track complications and problems and so on. And so, it was just a time when web-based medical records had just started to show up. And it seemed like the obvious technology. So we built that, and it actually worked out pretty well after a few bumps on the way. And then very soon after that, other members of PH, including Paul Farmer and Lunvio, were really establishing an HIV treatment program, one of the first two projects that actually treated very poor patients with ARTs. And that resulted in very good outcomes in a small group of 100 people. And then we're happy to have PEPFAR and the Global Fund, and not only going to 10,000 patients, but actually to millions of patients. And when that happened, we really had to have very good tools. You just cannot manage these patients long term. You have to have good access to the records, and you can't have paper records going missing, which would do a lot. Typically they're very difficult to manage in low-income settings. And so we built these systems, and ultimately we built a more general purpose system called OpenMRS, which was used originally in Kenya at AMPAF, actually, and in Rwanda and then South Africa simultaneously in 2006, and is now scaled to around 25 million patients, and I think about 6,000 or 7,000 health facilities. And so that gave us a tool which enabled to scale up, and actually PEPFAR uses OpenMRS as their primary system for tracking patients on HIV treatment, and that's allowed us to introduce decision support systems to improve quality of care. And we've then also been able to do studies to show how to improve the impact of these systems and the care processes. And now we're seeing use of the system for a number of other areas, maternal child health in particular, but also for oncology and non-communicable diseases, and some use of primary care, which I'd like to see more of. And more recently, we started to work on using data from OpenMRS and systems like that to develop machine learning models and to actually evaluate them rigorously in the use of ways of improving care in low and middle-income countries, such as in Kenya at PEPFAR.
And actually, I'm reminded that the first time I met Hamish was back in 2009 in Rwanda. So we go back very far as well. I remember that he pulled out this handheld ultrasound that just totally blew my mind. And, now we all have one in our pocket. But at the time, Hamish was the only person in the world I knew. So now to Rochelle. When it comes to developing new AI and digital health tools, most of us think about the role that computer scientists play, physicians, other medical specialists, but not necessarily anthropologists. Tell us about your work and why the human aspect of artificial intelligence is so key.
Yeah, Stephanie, you said if you ever thought I'd be on a panel with AI and digital health, well, nobody ever thought I would be here when I went to graduate school to be an anthropologist. But I'm principally a qualitative analyst and qualitative data gatherer. And about 12 years ago, someone I had worked with on a qualitative project said, do you think we could use the tools you're using to develop an app for HIV adherence? For HIV meds, we want to represent what sort of adherence, we want to represent adherence and the state of someone's adherence in real time visually on an app. Can you help us do that? And I thought, yep, we can take the tools that we have for qualitative work or cognitive interviewing and transfer it to figuring out how that works. And I have continued to do that for, the last 12 years, and thinking about app interventions that are delivered on apps, interventions that are text-based and delivered in text messages. We are a very well-networked panel because I get to work with Stephanie and Adam on Adam's project, developing fluid calc in both Bangladesh and Tanzania. So that's an app that helps doctors think about how to rehydrate patients with diarrhea. So we did focus groups with doctors about what they might want it to look like, and helped bring their voices to the table so that Adam and the app designers could iterate the technical side of it. We know that whenever a new technology is in place, there are at least 3 ways to look at it. We need to look at the systems that deliver it and the people who use it, and those people are both the clinicians on one side and the patients on the other. So we know that technology is going to affect how care is delivered and the way medical results are interpreted. And my job is to help figure out some of the ways both sides or all the sides in that equation figure that out.
And I've been so thankful to Rochelle and her colleagues over the years for providing so much incredible input into our research studies in Bangladesh and Tanzania and now here in the United States. It's one thing to create a new machine learning model and perhaps to create a algorithm that is perfectly sensitive and specific and effective. But if nobody is using it, what's the point? If you don't have a way of getting individuals to actually put it into practice, you don't make it usable and feasible for them to use during their busy clinical practice, which all physicians, all nurses, all health workers everywhere in the world are busy, but people working in low resource settings are especially busy. If you don't make it simple and easy for them, then they're never going to put this tool into practice. And so that is where I think Rochelle and our team have really helped us over the years. I'm going to open up some general questions for everybody. And obviously, we are a Center for Global Health Equity. We think about that very broadly as basically trying to reduce inequities in health wherever they occur in the world. And I'm just going to start us off by asking, how can AI and more generally digital tools help close the gaps in access to quality healthcare that exist in low resource settings around the world? And maybe some specific examples from your experience to make it concrete.
Yeah, I can start off, but I'd love to hear what my panelists, co-panelists also have to say. But I think my perspective is really coming from, I think at my foundation, I'm a clinician, I'm a doctor, and I want to see tools that actually work and are practical and cost effective. Even, not just some tool that is cool and shiny and new. So I think one of the issues with equity and how we can use these tools to improve equity is really by replacing some of these kind of traditional models of healthcare technology that we use. For instance, in the project that we have currently in Bangladesh, trying to create a new digital-based system for pediatric sepsis. Sepsis is a really challenging problem everywhere. I don't know that anyone can really say that we do a great job with sepsis anywhere because it's so broad. It's really difficult to monitor. People can look okay 1 minute and literally the next minute be extremely, extremely sick and die. And one of the ways that digital tools can help with improving these gaps in care is that if you go to the ICU here at Hasbro or at Rhode Island Hospital, someone with sepsis, this is one of the sickest people in the hospital, and they'll have, huge amounts of resources dedicated to helping them. They'll be in the intensive care unit. They'll be hooked up to continuous monitors. People from across the unit will be able to see what their heart rate is just by looking at a screen. They'll have access to ventilators, to special medications to support their circulatory system, and a number of other interventions. And for the most part, in low resource settings, you're kind of limited to just a few things like giving antibiotics, giving fluids. A lot of times there isn't, even an intensive care unit in that hospital or even possibly in that region. So one way that I've seen the potential for digital tools to really bridge this gap is by replacing some of these really expensive tools, spaces, technology, the infrastructure. The cool thing about digital tools is now, like, everyone has a smartphone. We have really powerful computing systems that are increasingly accessible to everyone, and seeing clinicians use these on a day-to-day basis. My colleagues in Bangladesh, in Rwanda, all have smartphones too, just like most of us in the room do, and use it for personal use, for communication, for medical decision making. So if we can figure out ways that we can ethically and equitably use these tools, we can bridge a lot of these gaps in care, I think.
So I think there are obviously a number of huge challenges in how we improve quality of care in low middle countries, and particularly in very rural areas where there's particularly short supply of medical expertise and trained staff. So when you have an information system in place so that you can actually manage those patients at a distance, you can start to improve care. For example, using mobile devices with community healthcare workers, which had a huge impact around the world, including in Bangladesh. But you also then want to provide the kind of local expertise, helping to manage patients, who, for example, have worrying symptoms, and you can use some of the more rule-based guidelines to do that, and many people have actually implemented those, but the accuracy and effectiveness of those kind of guidelines is not that great. And so there's a real potential to use more effective diagnostic tools, AI-based tools. The this is an area, my sort of other hat I wear apart from the global health piece is actually looking at diagnosis and triage in US context, both in Rhode Island Hospital and in Brown Health, and we're looking to also work in Maine. And using symptom checker apps, and then more recently, of course, large language models, and really trying to understand how well these systems work, what's accurate, when they're accurate, when they're not, and what the risks are. And I think that there is some huge potential for these tools to really make a difference. And I'm very excited about the progress, but at the same time, amazed about the almost total lack of evidence for any of these kind of systems, and that includes here, and in the US, and includes really all low-income settings where there is essentially no research base for AI use in medicine in an actual clinical evaluation context, with the exception of a certain study by a couple of my colleagues here, and a couple of other studies, including the one in Kenya. There's really nothing being published. So that's a big problem. We've got a lot of work to do, but we do have the tools and we do have the potential. And so particularly for imaging type systems which use convolutional neural networks, which are kind of the generation of really exciting technology just before LLMs, those systems are a lot more stable. I think deterministic is the right word, where they give you the same answer if you use them twice, which is not always true for large language models. So we've got lots of great tools for retinal scans. We can use them for example, TB diagnosis with chest X-rays, and there have been some studies in places like Malawi doing that, and also improving areas of pathology diagnosis. So there's lots of really well-established tools, and there's lots of potential, but we really need to be working very closely with people in each of the communities where they're going to need to use these systems, and actually coming up with genuine clinical evaluation. And also another huge important piece, which Rochelle, of course, has been talking about, is how do you communicate information effectively so that people make better decisions? And we really don't know that very well. Even, for example, radiologists using systems to improve diagnosis of mammograms. How do they incorporate that information in their diagnosis and decision-making process is still not entirely clear.
And I'll just add that in all settings, and I think low resource settings in particular, it's terribly important to make sure that we're asking what are the community needs. There's a lot of, there has been a history of developing for and not enough of a history of developing with. And so I think that's certainly the perspective of anthropology and qualitative research. And actually also of all of the doctors I've had an opportunity to work with, a strong sense of listening to communities, because nobody wants a shiny new thing that doesn't work there or isn't appropriate. So asking what people want is and designing in a participatory way is terribly important.
Yeah, it's interesting hearing what all of you had to say. Similar to you, Stephanie, I did not start my career thinking I was going to be working in digital health or artificial intelligence. And in fact, when digital tools like apps first started coming out and started being used a lot, and there was interest in them being used in global health, I was the first to say that an app is not going to save the world. And I knew that from what I saw on the ground, which is at the end of the day, the only thing that actually provides healthcare is a human being taking care of a patient. And you could have the shiniest equipment, you could have the nicest hospital, but if you didn't have health workers trained to use that equipment and to work in that hospital, then you were not going to get care provided. But if you had health workers who knew what they were supposed to be doing, they could advocate for things that they didn't have. However, I still have that belief very strongly that the center of a healthcare system is always going to be the human healthcare professional, whether it be a nurse or a community health worker or a doctor. But I am ready to add now, after years of doing this, that if we can make that person's job a little bit easier, then that will be a huge win, both for the healthcare worker and also for their patients, and then more broadly for the healthcare system. And I think that's where these new tools, apps, and then nowadays artificial intelligence really come in. It can make the job of a busy healthcare worker a little bit easier, and can it make them a little bit more effective at doing what they need to do. And that's especially important when we have shortages of healthcare workers all over the world right now, and we need more people doing this.
Can I just add an example from one of your studies? So when we were working in Bangladesh on the Narudak app, we did these focus groups where we showed people the app and talked to the doctors and the nurses about how they wanted to input the information, what did they want the results to look like, a lot of sort of what you might call user input or user experience. And when we went to analyze it, we analyzed all the details of what all of those screens, those cards looked like. And when I was doing the qualitative analysis, I had deductive codes for all of the questions that we'd ask, so I could bring them back to Adam and to the app designers. But I created an emergent or an inductive code for clinical experience, because we'd ask these they were challenging to ask, really sophisticated questions about the specificity of the algorithm that people wanted in the app. And we got amazing answers. But over and over again, the clinician said, yeah, the app's great. Yes, I'd be happy to use it. And I'm going to use my own clinical experience. I've been doing this for 17 years. Your app is great. It's very helpful. And I'm always going to filter what I get through it through my experience. So I'd say there's AI and there's HI. So human intelligence, clinical intelligence is never going away.
Yeah. So next question I have is really getting back to my history as a little bit of a pessimist around these things. And I want to ask you guys, how do we ensure that these new tools we're developing are accurate and effective and not hallucinating answers like ChatGPT will sometimes do? I think the term hallucinating is really funny and cool, but really what we're talking about is non-specificity, right? And so this has been a problem in diagnosis from the beginning of time, where you have to balance your sensitivity at not missing something with your specificity of not over-including things that don't belong. And how do we really ensure that these tools are creating that balance, number one? And number two, how do we ensure that physicians, nurses, clinical officers, community health workers trust these tools, which is sort of an extra step beyond just making sure that they actually are accurate and effective?
The kind of question that I like to look at in my work. So how do we do studies where we use these tools in real clinical settings with typical patients, and no kind of smooth the edges, make it easier, whatever, just actually throw them out there. And of course we have plenty of challenging places to work, so we have good examples to do that, but we are seeing, I said, a real dearth of studies that look at prospective evaluation in a clinical setting. And so we see lots of papers published, thousands of papers published with wonderful metrics based upon the test set of data they collected some time before. And they declare victory, and nobody ever does any kind of clinical testing of these systems. So it's incredibly important that we see what happens in real world settings. And it's been very interesting, and at AMPATH, building the system out based upon the OpenMRS medical record system, taking the prediction model that was based on the research data set that AMPATH generates from OpenMRS every 4 months or so. And Alan, one of our PhD students, developed these models along with Joe Hogan and others, and came up with reasonable predictions for patients who are going to miss a visit or be lost to follow-up. But then we actually implemented it into the EHR, and that meant we had to have real-time data from the night before, so that data is in a slightly different format. It was not more recent data. And the model's performance went from an RSC curve of about 75 to about 54, which is basically useless. So then we retrained it and adjusted it, and we ended up with a better model, which is slightly higher performance. And that was the model we then implemented in the system. But then we have to track when people generate these lists, whether they call the patients, what the response to the call is, and we've created a complete network of tracking how the system is actually being used and then how it's impacting on patients. And so only through that kind of system, using the electronic health record as the background, are we now able to start asking really hard questions about, when does this seem to work? And in this large randomized controlled trial, can we hopefully show an impact from the system? And it's that kind of work that's going to need to be done. It doesn't have to be that scale to begin with, of course. You can start with smaller observational studies and see, in a particular situation, does the system for example, a diagnostic system, does it produce appropriate diagnoses? When does it go wrong? What kind of errors does it make? And then use that information to try and make the system more safe. But again, there are very limited numbers of studies. There's one with the ADA symptom checker app, which I use a lot in my own research, where they tested it in Dar es Salaam and modified the system, adding about 148 new diseases. And then they used it with both patients and with district health officers, so like a sort of physician assistant level person. And we're able to show improvements in diagnosis and treatment decisions used by the healthcare workers using the system. So there are examples, but there are very few and far between. And unless you see this kind of data, then you really need to take a step back, I think. The only really big example we've seen recently is for primary care in Kenya, in a private primary care system called Penda Health. And they had basically a collaboration with OpenAI and using ChatGPT to do the diagnosis for these patients and try to help the district health officers staff to make better decisions. And their initial results look promising. They claim to have used this with about 40,000 patients. When you peel the layers off the paper, you finally find there was a prospective observational study of 1,300 patients. And the other pieces didn't quite fit. So good step forward, and there's an RCT on the way, but we have a very long way to go to have the evidence for this.
Recent meta-analysis of AI models used in healthcare found that less than 5% of them had been validated. Essentially, there were lots and lots of derivation studies, but very few validation studies showing that these models actually work outside of the population that they were first derived in.
Yeah, I'll also add less from a data science perspective, but I think just in general, from looking at the history of clinical research, is that we need to be more inclusive and more thoughtful about who and what communities, what patients are involved in research. And historically, we have not done a very good job having more community engagement, patient engagement at all phases of research is still really not done to the degree that it should be done. So I think when trying to answer both of your questions, Adam, I think about inclusivity and representation, and especially thinking about AI and potential for bias in AI and global health. There's just a huge, we're kind of at a critical point where we can either, really make huge changes to level the playing field across countries, across regions of the world. But if we do kind of what humanity has done in the past, unfortunately, we stand the risk of just making these inequities even worse. And when you look at the representation of where AI is really being developed and used, it's really being used in rich, wealthy, high-income countries in North America and Western Europe and Australia. It's really not being developed for and with communities outside of those major regions of the world. So, and then even within the United States or other high-income countries, there's these, large disparities in terms of who has access to, being represented, their data being represented or being used in models based off race, gender, age, especially with digital literacy being widely variable between different generations, and then different marginalized groups that just don't have the same access or don't feel included or part of the conversation. So this question of, I think, inclusivity in AI is really important. And I think also goes towards, how we can actually build trust. We all need to be part of the discussion of AI. Everyone does need to know a little bit of programming, I guess, or maybe not even that, but just having digital literacy be just a fundamental expectation so that children, as they're growing up, especially now with I guess they're called Gen Alphas or something now, but, these new generations will be much more literate than I think any of us here, even in this room, even the medical students here. And that's going to go a long way towards understanding just the fundamental concepts of whether these models, these tools can be trusted, if you're able to explain it, if, these models are not explainable, you're not going to convince anyone, especially a doctor who might be very skeptical already, to use that tool.
Great. Well, that goes actually into the next question around ethics and community ownership. And Stephanie, I know that you have a supplement on your current project in Bangladesh, specifically a supplement, specific funding from the NIH to study the bioethics of doing research on AI in low resource settings. And so I don't know if you can tell us a little bit about what drove this supplement and what you're learning from it now, and what advice you have to folks who want to do this type of research in low resource settings.
Yeah, as much as I didn't think I'd be on a panel about digital health, I definitely didn't think I'd be doing research on bioethics. There are many people that are much more experienced in that field than I am, but it was something that was that's the high priority in medical research. And we are currently adding on to the study that we have in Bangladesh, which is about developing digital tools for pediatric sepsis. Now a additional sub-study, which is looking at ethical considerations of doing digital health research, especially in pediatric populations, and especially in very vulnerable communities. The hospital we partner with is a public is a nonprofit hospital. They don't charge patients any money to get treatment. It's a huge hospital, the International Center for Diarrheal Disease Research in Bangladesh. And as a result, they care for a very disadvantaged and marginalized population. Very poor people generally go to that hospital. And we were really interested to know, we had gone, 3 years basically of enrolling patients in this study, of enrolling the mothers, the providers of, children with sepsis. And we really didn't understand what their understanding was of things like the consent process. I mean, here, even consent process, when I go to my doctor and sign a consent form, I'm like, yeah, just sign on the bottom line, and you don't always understand everything. And then we were looking at our own project, which involved machine learning and modeling and mobile health tools and wearable devices. And we were really interested to know, like, what did the participants who so generously agreed to enroll in our project, what did they really understand about the consent process? What did they understand about the data that was being used? So I'm very fortunate to be working with my colleagues and my colleague Alicia Janiska, who's a pediatric emergency physician here, to really look and just do some basic understanding of from the caretakers' perspectives, and also from hospital kind of governance standpoint, the IRB members, senior scientists who aren't necessarily working in digital health, but what is all of their understanding of ethical considerations with digital tools? And it's very early research. I would say we tried to look for papers, on this topic, and there was almost nothing. So it's really interesting to see what the understanding is. And the preliminary results, because we're still collecting data right now, is that, the parents of these children, they are really invested in understanding and using these tools just as much as any of, I think, us that are doing research. They also see the potential for this to benefit, their child or children or other children like their child who's very sick. And that they can be engaged in discussions with, we're using different kind of infographics, since not everyone has the same level of literacy, and using simple descriptions. And people can understand these concepts and really contribute to the research. They just need to be asked.
Based on Rochelle's earlier comments, that some of the leading experts and people who've done the most work in global health are actually medical anthropologists, Paul Palmer and Jim Kim and Raju Castro and many others, actually Gary Clifford, who is the head of health informatics at Emory University and does a lot of really amazing work on child health in places like Guatemala. His wife, Rachel Clifford Hall, is an anthropologist, so they have a team. So I think this is a very valuable way of looking at things, where you have to try and get out of your own space and make sure that the local teams and also the patients have a real role in deciding what you're going to do. And we've been fortunate to have many projects where you do get that kind of feedback, and also doing some qualitative studies as well, getting similar comments at AMPATH, that the clinician said that they were interested, but they wanted to make sure that their judgment wasn't removed from the process. So again, this came back. So I think one of the odd things about large language models like ChatGPT and so on is that they are so easy to experiment with. And so there are lots of people doing really interesting experiments all over the world and developing their own ideas about them. So I think there's a certain element of democratizing research that's going on there. I worry about exactly how much you can figure out, because none of us really know exactly what's going on, but it's actually creating a new space for people to experiment. So that's a really interesting possibility to move forward with.
Yeah, it'll take us into our next question, which is really around standards and governance. And, how do we ensure sufficient standards and governance for digital tools that are being created for use, especially outside of the US and Europe, where laws have yet to be developed or are quite weak around data protection and AI? And even within the developed world, obviously Europe has much stronger data protection laws than we have in the US. But, in doing this work in various places, I've found that many countries have no laws around it. And so how do we ensure that there are sufficient standards and that there are protections built into our tools for our patients and our providers?
I think that these are very important questions and very serious questions, of course. Some countries have really taken the lead in this. And so I think in East Africa, certainly Rwanda and Kenya, and I think probably Uganda as well, have done really interesting work in this area. Rwanda, as often happens, were badly burnt by a certain international university research projects where they took the data on all the HIV patients away to the US and analyzed it and published papers, not including anybody in Rwanda, but also not having permission to take that data out of the country. And there was a very big pushback, and they were basically chucked out. No further research took place with that team, but also Rwanda then established a secure data center for medical data. So any data project you're doing in Rwanda, which is collecting medical data, that data has to end up in the national secure repository, and then there are various rules to manage that. So, there are tools around that are being used more effectively. I mean, obviously, the biggest problem is so much of what we do now is online. It's in huge data centers in the US and other countries, and you just don't know what's going on. So that is a very big concern. In the projects we're starting to look at with large language models for the work in Kenya, we've actually been using Llama, which is the open source model from Meta, and there's one on the Brown network, so we've been able to do some experiments with that where the data stays on the network here, and in principle could be also installed at somewhere like Moi University and used. So there's a real potential pathway where there would be full control of that information, and I think that's going to be really important. The other concern, though, is transparency. So one of the motivating reasons for building open source medical records was a number of really bad experiences that people had early in the HIV epidemic when commercial electronic health records were being implemented and they were charging a certain amount per each patient. And then when the price went up because there were so many patients being enrolled and maybe a project couldn't pay for that, they would simply shut them down. And you had to pay to get your data out of the system. Basically a hostage-taking process. And it was really horrible. And so it was also interesting because there were these rules that said that, especially in South Africa, if you told people about this, then you could also be sued. There were secrecy clauses, which actually exist in the US as well until about 4 years ago for electronic health records. That's another whole story. So that has changed. And one of the reasons why so many countries have worked very hard to use open source systems is because of that control. So it may not always be the most easy and first way to do things, but they never have that situation where they lose control. And also in Uganda, which has obviously taken a hit with all the cutbacks in PEPFAR, they have local expertise to maintain the electronic health records. They have many people who've been trained over the years by our team and others, and same in Rwanda and in Kenya. So there is this indigenous expertise now in many countries, which allows people to take some control over the process, although it's far from perfect.
Great, thank you. So I have more questions, but I'm going to open it up now to the audience because let's hear your questions. And also, we'll take questions from our online audience. Those on Zoom, please go ahead and enter in your questions. And, we will try and see how our panel can answer those questions. And if you don't have questions, I'll ask some more of mine, but I think it would be better to get your input. So let's open it up. Who has questions? From Dr. Abid.
That's a very interesting discussion. So I have two questions. So one is, as mentioned by the panelists, that there is a data protection or data security measure. So that's sometimes that's a worrisome situation because the data may not be well protected or maybe lost, or there are other things. But in the global south, there is a growing concern about the human subject protection, kind of because there are not so many regulatory bodies or regulatory affairs. So when a funding agency going from the Western world to the global south, they are maybe very eager to give the IRB and other things sometimes. So that's concern is coming out from the global south, that whether there is an ethical issue about that. So how can that be protected, like that something is being done in the global south by the Western world, we are doing something there, which is ethical and which can be also done here. It's not just there. So that I would like to answer. Yeah, Stephanie.
Yeah, right now, I mean, I'm not sure I have the full answer to that question. I think one of the issues is that there currently are no widely accepted international governing standards for data, and different countries are doing different things or creating their own guidelines and protocols, but it's not really unified. One of the things that we're trying to do in Bangladesh is involve IRB members in our research. And I think that's, one way to start, in countries where they do have resources to have local ethical review, is really increasing the comfort and the literacy of people that make ethical decisions for research. Generally, have them have make sure that they're prioritized for training and education, because there are going to be huge numbers of projects. There already are, I'm sure, going to these IRBs, and people have really widely varying levels of experience in reviewing those applications or knowing, different data standards or protocols, and they'll also be different between different countries. So having people that are involved in human subjects protections really be prioritized, as well as, the healthcare providers, and being able to have a basic comfort with understanding risks of data security and involvement in research is, I think, really important.
An extension of that, Dr. Garbern, I really appreciate your comments about sort of the history of lack of inclusivity in research and how marginalized populations were excluded, and there's a lot of evidence of bias within AI based off of that exclusion. But I'm curious about your thoughts on a sort of flip side of that, where there's, of course, also this history of the Tuskegee experiment and other experiments in many global health contexts long after, where research was done on marginalized populations that would have never been done on wealthy, whiter populations. And how I think that could play in here is, one of the most common arguments I've heard for why AI won't be more widely deployed in healthcare, not just research, but actual practice, is that the liability concerns are just too great. If hallucinations happen in sort of a widespread way. And so how do you think of, on one hand, this sort of inclusivity challenge for who the data is used and trained on, versus, on the other hand, if there's asymmetries in like the legal mechanisms for patients who have received substandard care based off of an AI hallucination, to be able to reconcile that?
Those are great questions. I'm not sure we have the solutions for them, and that's why I think that's why we're at a really interesting place. Is we're just now seeing the first malpractice lawsuits for injury or now I guess death in the one case recently for I think chat for against OpenAI. So we're really like this is totally new horizons, and I don't think any. I mean, I don't have the answer to those questions, but in terms of, I think the inclusivity question, I think in some ways the ubiquity of these digital tools and AI, it really can level the playing field in terms of who is included in clinical trials and clinical research, because all you kind of need as a barrier to, joining is, being able to have, access to that information on the internet. So there is the potential to have, a much better new era of doing research and including those populations who previously were marginalized. And in terms of like liability, I think that's a huge question. And I think going back to like Rochelle said earlier, like a tool will never replace humans. And in the end, liability will always lie with the humans that created those systems or who use those systems. Clinicians will always need to filter whatever their app tells them through their own clinical lens and judgment, and take responsibility for, understanding that output and how it was generated, so that they actually do, truly have responsibility if that result or that recommendation results in a bad outcome. So I think at the end, there will be systems in place to address liability, but at the end, it's going to be, I think, still based off of that human, decision-making component, that at the end of the day, it's a person making a treatment recommendation based off of the best available information that they had. And the responsibility, will lie with, clinicians as well as industry, developers to have that information. But I'm curious what my co-panelists have to say also.
I've seen over the years is that the very different environments and the challenges of working in low-income countries such as in East Africa have created really new opportunities for innovation. And so a lot of the most innovative mobile health applications have come from low and middle-income countries, and some of those are now used in the United States. And Comcare, as an example, developed in Boston, originally by Neil Lesh, who was working in Rwanda with our team, and decided that we needed a tool to support the community healthcare workers. And that has actually been used in the US on a number of occasions, particularly during COVID, but at other times as well. And so the way that people are using technology is different, and there are opportunities to look at different ways of doing things. Mobile phones can be used to do all sorts of really clever diagnostic tricks, particularly around using the mobile phone camera with adapters, for example, for malaria blood smears. And that was something they were doing in Rwanda while we were there, just testing out examples like that. So I don't think it's one-sided. I think that there are great concerns because of the power dynamics and the funding dynamics obviously are very difficult. But it is also interesting that DeepSeek is sometimes pulling ahead of ChatGPT in terms of its performance. A paper in JAMA like a week or so ago, it was significantly better at diagnosing complex eye diseases than ChatGPT 4. Actually, was one of the most sophisticated reasoning models of ChatGPT, and they worked out that the cost was about 1/66th of the cost of using the OpenAI model. And it's also an open source model like Llama, which could be installed locally. So it's not quite as asymmetric as we fear. I think there's some interesting possibilities there as well.
Yeah, and I would say too that, just as the final decision making lies with the, healthcare worker providing care for the patient in front of them, and in our Fluid Calc app, we're careful to build that into it to say that this is for guiding clinical care, not replacing a clinician. The responsibility also lies with the researchers who are conducting this research. Number one, responsibility is to actually conduct the research to show that the app or the models or the digital tool really works and that it works in the populations that you want to serve. And then publish that, because much of the work, this is why I have such skepticism for so many of the AI tools that are out there, is because none of them are actually peer-reviewed and published, or many of them are not peer-reviewed and published. In that way, we just have the company to trust, basically. And after you publish that data, and in addition to publishing that data, your job as the researcher to ensure that you're, making sure that your population is providing consent for that data, that they understand the data that they are providing and what's going to be happening to it, and that we create systems so that we can do this research in an equitable way in the places that we want to serve. Without sort of those steps in place, you're right that there's going to be huge risk for that data to be misappropriated or to be used even to harm the people that we're trying to serve. Yes, from our friends from Germany here. Thank you.
I was very intrigued by your early diagnostic system on sepsis, and also what we talked yesterday about the diagnostic of extrication. Also because I once worked in Bangladesh 30 years ago in the diarrhea clinic. But the point is, how long do you need to train these systems? I mean, I imagine training cannot be on site because for that you need more calculation power, I suppose. But how long do you actually take to implement such a system? From the inception to the implementation?
Well, we're still in that process now. So the project in Bangladesh is now in its 5th year, and it was based off of pilot projects that were even before that. So that's just one example, but these take a long time to collect this type of information, especially, even 5 years ago, we were using these little wearable devices that are not dissimilar to like an Apple Watch that's stuck to your chest. But 5 years ago, there were many fewer options for wearable devices than even today, and that's not a huge span of time. So in terms of the length of data collection and how much data you need, I mean, I would say there's depending on what the disease process is, it's going to change how much data you really need to create a model. But going back to what other co-panelists have said is, even if you have a model that works great in this one population, there's a very good chance it's going to work really poorly in another population, and you either will need to revalidate it in that population or apply some other algorithms to be able to localize that application, that model to that context. So I think it's a really difficult question to ask, and one that we need, huge amounts of data from diverse populations to really create tools that are really usable by large numbers of people. But for instance, in Bangladesh, the models we created are just based off of 100 children right now, and they perform quite well. But we're in the process right now of seeing, in the same hospital, is it still going to perform anywhere near as well as it did when we created the models? And we still don't know the answer to that question, but that will certainly be a big problem, I think, for all of these types of models, is that, what works in one setting might not work in another setting, and we really need to have it be representative, and also for people to trust it. I think we see in research all the time that people trust research when they've seen that past research and the people that designed and led that research are people like them. So it's really important, I think, for all of these research projects, especially if they're, tools that you want to be, globally used, that you really are including as many people from all walks of life and expertise in your development from an early stage. Definitely. Sepsis and many other infectious diseases have a seasonality component, and now I think issues with climate change are also changing. What might have worked for a model 10, 20 years ago might be totally different in 10 years from now. So the pace at which things change in AI, I think, is really challenging, especially coming from academia, where our grant cycles are so slow, and to be able to keep up with all of industry and other people, it's really challenging to have these things go as quickly as you and be developed as quickly as we'd like.
I would just make one quick comment. There's a vast range of new assays and diagnostic tests that are becoming available. And there was a Lancet Commission on Diagnostics in low-income countries about 3 years ago, which identified a huge number of low-cost, robust systems And then we had a couple of meetings with a group at Oxford University on how to combine the informatics side of things and the diagnostic side of things. So that I think, although there are these various issues with AI and with the generalizability and so on, there are also these new signals and new types of data that we can feed in that are a little bit more precise on certain issues. So I think it's not just sort of taking very general EHR kind of data, but actually bringing in the different kinds of sophisticated test devices and adding that information in, which I think will give us an edge on this process.
Other questions? Yes, right here.
So I have a couple of reflections that I'm going to contextualize my question. I think one of the things that I think about when I think about technological development in medicine is the classic, like, we created EMRs, and so now we have some, like, different EMR systems that don't talk to each other, so a patient with one street between two facilities can't connect the data. And then when I think about global health, I also think about how there's so much good work going on, but we often face challenges in actually integrating all of that work. And I think as we're seeing this massive explosion of AI even more rapidly than regulations can keep up, and also that often is driven by, like, private sector interests as well, where is that balance of, like, the innovation, but also integrating all of these innovations that are happening so that communities and developers can get the desired effect of all of these innovations?
So one way that you can work with this is with systems that are locally managed and more open. It's a lot easier to share data and to actually exchange components and things like that. And so there is more control. I mean, one of the reasons why we're having so much trouble in the US is because the various private sector players are not playing ball. And even with the 21st Century Cures Act, which makes it a legal requirement to share data, it still doesn't happen all the time. And there's, blockers are a constant problem that the Office of National Coordinator, or it's got a new name now, have been working really hard to try and deal with. And fortunately, we don't really see so much of that because particularly the Ministry of Health will say, well, you can have certain EHRs in our country, and then you need to play ball, and you need to manage that. And so this is not a universal problem. And with HL7 Fire, which is a standard which has finally actually got its act together, works reasonably well. A lot of systems now support that and are actually plugging together quite nicely. So I think it's not as big a barrier when you have more control of the systems and you can actually adapt them more quickly.
Add to that, I think in global health and health equity in general, one of the keys is flexibility and realizing that, people are going to access these tools in lots of different ways. And so, my team, received $2.5 million from the NIH to build this app called Fluid Calc, which can predict the severity of dehydration in patients with diarrhea and help clinicians determine what type of fluid to give them and how much. And we're very proud of the app that we built, and it's now on the Google Play Store, and you can download it. But we also made sure that the app was up on the web. And so we have a web-based version for those who aren't able to access a smartphone and maybe using a computer at a desk. We also put it into MD Calc because we know that a lot of people aren't going to download another app on their phone, but MD Calc is the most used medical calculator. And so having our algorithms in there just make it more likely that people are going to use it. And we made sure to derive a score that you could just calculate with a pencil and a piece of paper, and you don't need an actual phone or any technology at all to use what is still a machine learning model, essentially, because there are going to be places in the world where people can only access it that way. And so ensuring that, really you have ways for people to access, what you're creating based on what they have available, I think is really key. All right, and back there, yes. You're next. Yes, please go.
So historically, a lot of the great innovation in AI seems to be coming from academia and healthcare, and scaling it comes from the private sector. With private sector companies like OpenAI and Meta becoming more and more involved, how do you see that changing the landscape landscape of the healthcare in the US and the foreign countries, and how do you think we could bridge the gap between public-private sector and academia to enhance the outcomes for both patients, clinicians, and the users of these AI algorithms?
Great question. And I think one way that this explosion of kind of accessibility of these models can be used is, I think just being able to have the data and have academia, like we're historically not, I think, very good at partnering. And I think going forward, we need to really be much more comfortable, especially from academia. I don't know, I've never worked in industry, but really more comfortable in partnering with industry, especially as we go from more pilot stage projects to thinking about scale up or integrating models like OpenAI into actual clinical practice. We just need to be working together more. I think I've been pleasantly surprised by how much industry, wants to work with academia, but sometimes it doesn't seem like it's the same the other way around. And it really can be a mutually beneficial relationship. And at the same time, in healthcare, especially in global health, we're almost never going to be the profit-making arm of a company. It's really hard, and part of the project we have in Bangladesh is, it was at a kind of a very challenging point a few years ago when the company we were partnered with got bought out, and essentially they were not interested in treating poor kids in poor countries like Bangladesh. And they were basically gone from the project. So there are lots of real challenges, especially working with, smaller or mid-sized companies that, they really can't take a lot of risk in terms of investing in projects that might not be successful compared to, maybe someone like Meta, where they could probably, take a lot of risks with projects and still be okay. But I think that part of, understanding, where industry can really help us with our goals, and then also understanding that healthcare, is really, at the end of the day, it's not about, it shouldn't be about making money. And that's where academia can, I think, step in. Governments, nonprofit organizations can step in, but it really has to be more collaborative. But I'm not sure that answered the whole question. So.
It's a really big question, and I can't begin to answer it. It's the question we should all be asking. I'll tell you that I think I'm an academic, I'm a researcher, and I think academics and researchers write for each other. A lot of our information still exists behind firewalls. A lot of that is changing. But I had the experience of sharing a medical article with a family member who read it and said, I don't think that was a very good study. Did you read those limitations? I'm like, well, they have to write about that. But I realized that the form is just not accessible. The way we write is just not publicly accessible. And that's going to have to change. And it's certainly going to have to change about AI and AI tools, because people are going to use them whether we're communicating well about them or not.
There's a couple of observations. I mean, one is that, there are companies that are interested in collaborating and building really longer-term collaborations, partly to really try and improve their product. And so Ada Health, the company we work with, we don't take any money from them. We pay them at the moment to help with our studies, but they've been very open to allowing independent research. Many people have done evaluation studies and published them, and they don't insist on having authorship or control over that. So they've actually ended up being one of the strongest companies in their space because their system is well known and it's also been well tested. And many other companies in the symptom checker space have not been tested, and when they occasionally do have an evaluation, it doesn't actually work out very well for them. So there's a benefit there. It's also uncomfortable for companies. They don't really like evaluation, but if you don't do it, then bad stuff can happen. And Babylon, which was a company that one of the early symptom checker companies that was extremely hostile to any kind of medical input or collaboration, actually grew to being $4 billion and then vanished in about 6 months because they didn't really have any there. So there is that aspect. But I think also that there are real concerns if we don't have those collaborations working, because then how do we know whether these systems are going to be effective? And so it's a risk to companies. I mean, in a way, it was risk to the HR companies to do the High-Tech Act because they really weren't ready for prime time. And after about 4 years, people suddenly thought, these things are horrible. And there was massive pushback because they hadn't done maybe 6 months of or a year of preparation. They hadn't done the usability testing and really basic stuff. So I think that there can be, great opportunities to help companies be more successful, actually, and then produce a better product that we all use.
We have some questions from online.
Yes, we have 2 questions from online. The first is from Bill Nardi, and they ask, can you speak to the role of researchers and clinicians, not just in testing AI systems after they've built, but in co-designing them with patients and communities, and continuously monitor them over time for safety, accessibility, and accuracy, and potentially share examples of how this has worked in practice?
I guess I'll go because I'm a practicing clinician, and that's exactly what I think my role is. Like, I'm not a software developer. I'm not an engineer. I'm not an AI expert. And clinicians, of who I know there's probably a lot in this room, or people going to be clinicians, that role is really critical. And I think sometimes overlooked, as well as anthropologists and implementation scientists, is you need someone that has that real world experience, who's also kind of the mediator between, a tool like ChatGPT and like a patient who's just, looked up, what problems that they have online. So that clinical expertise is really needed at every phase. And not just the clinical expertise, but implementation science is another area that's really been understudied. I know one of our panelists couldn't make it, but Rochelle's done a lot of work in implementation science, and that involvement of different types of stakeholders is fundamental to, especially for digital health research, in being able to understand the data, translate that data, design these tools so that patients are involved, and or whoever the user is really is involved, so that this is something that actually can be helpful to people.
Second question. They say, ideally AI tools should have been peer-reviewed or vetted by IRB-style boards before they were released, but unfortunately that isn't always the case. Do you have recommendations on how researchers can peer-review them now for use in medical settings? Any examples?
That's what we're doing. So we've got a whole bunch of data from patients using the ADA app, so they actually present to the ED, and we recruit them to enter their symptoms and background information while they're waiting to see the physician or in urgent primary care. And we have a set of 250 cases we're currently using, and another, I think, 120 or so we've collected in the last few months as we kind of ramp up the study. And so we can then take all these different large language models and test them out against this, compare their performance, and look what kind of things are occurring. So there are definitely ways of doing that, and I think it's really urgent because there's so little information that's been done. There was a talk I was at, meeting at Beth Israel Deaconess on Friday, and they had people from Open Evidence, some of the original developers, talking about the system. About a year ago, there were about 1 million consults from physicians in the United States and medical students. Now there are about almost 13 million a month. So it's gone up by a huge amount. And when people asked about the evidence and publications and evaluation studies, there currently aren't any. Think about that. Tens of millions of consults every year by physicians, but nobody actually knows much about the system. And so they've apparently just contracted with some outside researchers to start looking at the system. So that's a tool that people really rely on and I think trust a lot. So it made me a little concerned. So we are looking at that too.
I mean, one thing to remember is that it isn't in the financial interests of many of the private sector actors to actually rigorously test their tools, because all that's going to show is that they don't work and they're not going to make money. And even if it showed that they do work, that's not going to make them more money than just putting it out there. And on the flip side, in academia, there's often not funding to do essentially validation testing. And what we probably need much more of is funding for validation testing to ensure that things that have been created, the new shiny thing, actually works. And also implementation science to see, now we know that something works, how do we actually get it into practice? And I think there is a movement in that direction to have more funding in that area that will hopefully help us have better tools in the future that we can all feel comfortable with. We had a question up here.
Implementation settings, what do you wish like regulatory boards would include in terms of community inclusion and utilizing their voices in the tools that they're being implemented in their settings and in their communities? And also thinking long term, I know you guys aren't policy creators, but what do you wish like some policy recommendations are for including communities where these things are being implemented?
Well, certainly, just because you can get some, I want to rephrase that, because you have successfully gotten through an IRB at your institution or in the global north, you need to be also working with IRBs when you're working internationally, representing the institutions that you're partnering with there or the communities that you're partnering there. So we have globally now examples of community-based IRBs. So they're not even representing the institution. They are thinking about their there are IRBs that look at that are made up of people from the communities that are deliberately affected by the research. So I think that seeing more of that so that we actually have local perspectives, local cultural values, and local eyes on the research. And then additionally, certainly whenever we work, it behooves us to make sure that the results of our research reach the communities we've partnered with. I think that should be self-evident in environments like here. I think it is, but I also think you can't say it too often. And I think that that should be good policy. But you also have to teach people how to do it. It's really, as a young researcher, one of the first things I did was talk to the board of the community agency that I was working with because my PI said we're doing that. If I didn't have a PI who taught me how to do that, because it's a little intimidating, you have to learn how to do that well. I had a role model, and then I also, that became part of the model of why it became important and essential to do it all the time, at the beginning, in the middle, and during the results of the project. So those are some of the things I think I'd like to see happen.
One of the projects that we're doing in Rhode Island with Kathy Eller, an educator, a long history of doing research with high school students in Rhode Island, is setting up these datathons where the students are actually doing a data science and AI course in high school. And then we have about 50 of them come through in last June and then also the year before. And then they were able to look at different kinds of experiments with different kinds of machine learning models, and a bunch of experts from a number of universities as well as Brown working with the students so that they could get their opinions and they could try out different, some of our cases for diagnosis with ChatGPT, and they looked at different ways of using convolutional neural networks to recognize images of dogs and cats and things, and then some of the limitations of doing that, so that the students get a sense of what they can do and what they can actually start to innovate in, or at least to understand what's being done to them.
So I'm going to finish with our last question. This is for each of you. If you could go back in time 10, 15 years and give one piece of advice to yourself before you started this journey into AI and digital health tools for use in reducing global health inequities, what piece of advice would you have given yourself? Start with Hamish, then go to each of you.
That's a tough one, actually, because I think it changed so much. You know, when we started 25 years ago, there was such poor technology and it was such a challenge, and there were only very specific things you could do, like sort of telehealth, store and forward images and so on, whereas now you have this wealth of things you can use. So I don't know. I think probably getting more involved at the community level with the design piece earlier would have been good. And we were able to do some of that with the OpenMRS thing because it required a lot of people to come together, and we learned some lessons from that. But I think earlier on, getting more, building up more expertise in the communities at early stage would have would help to push that forward. And we see that much more now.
I think going back 15 years or so when I was in training still, I probably would have said, I would have liked to tell myself that you don't have to be the expert. Digital health is really complex and cross-disciplinary, and I think can be intimidating also for a lot of people that might be interested, but there's a lot of skills. Then you get, software engineers that are just at a totally different kind of like level than you might be. But knowing that your expertise and also your ability to really understand real world problems and speak on behalf of other clinicians or also advocate for patients is really important. And I think I would have told myself to listen to kind of patients and communities more so that would help me direct kind of my research interests going forward.
I may still do this, but I would have learned to code. It just wasn't part of an anthropologist's training.
Grand rounds, and feel free to pick up one of our brand new Center for Global Health Equity brochures on your way out. Thank you guys so much for being here.
This is fun.